Hi guys, welcome back. The next topic we're studying is neuromyelitis optica spectrum disorder, and this is always asked at the exam in comparison with multiple sclerosis. The key word in the question in favor of neuromyelitis optica would be a young female, either Asian or African descent, and there's going to be a bilateral optic neuritis. This would be in contrast to multiple sclerosis, where he's going to talk about a white female, Caucasian or North American female with unilateral involvement of the optic nerve. I did not use the word blindness for multiple sclerosis. Most of the time the description given will be a decrease in visual acuity, a decrease in color vision of the patient. Yes, blindness can occur, but on a comparison basis, I can say for neuromyelitis optica, the bilateral optic neuritis and the progression to blindness would be faster. Supplementing this and over and above this would be a spinal cord involvement. Well, you might say, what's the big deal? Because spinal cord involvement can be seen in multiple sclerosis also. Agreed. But with respect to neuromyelitis optica, if you scan through this image, you can see the hyperintense lesion spanning multiple spinal cord segments. At least 3 consecutive spinal cord segments can be involved. And therefore, another keyword in the question over and above bilateral optic neuritis would be longitudinally extensive transverse myelitis. The definition of this I will write subsequently, but I'm saying verbally at the moment would be at least 3 or more contiguous vertebral or 3 or more contiguous spinal cord segments getting involved in these patients. Apart from this, obviously the MRI would give us evidence of optic neuritis, and lots of time helping us even further. He might talk about the villain antibody in this case, which will activate the complement system, and the name of this antibody is anti-aquaporin 4 antibody. This would damage the water channels. This would affect the food processes of astrocytes where they meet with the endothelial cells. But make no mistake, this antibody can be negative as well. Well, can you make a diagnosis of neuromyelitis optica, or should you consider it in the MCQ as a possibility if he himself says anti-aquaporin 4 antibody negative? Yes guys, even in the absence of this antibody, we still will keep the diagnosis on the table. Well, we have additional MRI criteria for diagnosis even if the anti-aquaporin 4 antibody is negative. So I'll be teaching you those additional MRI criteria. I'll be teaching the core clinical criteria in the subsequent few minutes. But at the moment, the message is one: every time you read about an Asian or African woman with bilateral optic neuritis, longitudinally extensive transverse myelitis, think in terms of neuromyelitis optica, even if anti-aquaporin 4 antibody is given to be negative or has not been tested at the moment. Why do we call it a spectrum disorder? Well, you can see at image number E in this patient, that's going to be a lesion in the brainstem as well. You can see a cloud-like lesion in the brainstem of this patient, and therefore during the core clinical criteria, I'll be saying the word like brainstem syndrome, where I would imply that they can be crossed manifestations as well, because every time the brainstem gets involved, you have ipsilateral cranial palsy, and because the corticospinal pathway gets involved, you could be having a contralateral hemiplegia. So even stroke-like manifestations can be given in this question. Do not be surprised if you read about seizures. Yes guys, I'm talking about spinal cord involvement, I'm talking about cervical myelitis, I'm talking about bladder and bowel issues in these patients. But do not be surprised if a question talks about seizures and encephalopathy in neuromyelitis optica. That's why we call it a spectrum disorder, because it can easily be misdiagnosed as well, and seizures and encephalopathy can also be a manifestation of this condition, where we'll talk about a core clinical criteria by the name of symptomatic cerebral syndrome. Well, when I was a student your age, neuromyelitis optica was called as Devick's disease, and some authors prefer to use this term even today, the older authors, and therefore in the Q bank you might read about this term Devick's disease as well, which is the older term for neuromyelitis optica. Nowadays the term used is neuromyelitis optica spectrum disorder because of involvement of the brainstem and even symptomatic cerebral syndrome that can cause seizures and encephalopathy as well. So very interesting disorder with a wide range of manifestations. Now let's look at why it occurs and what are the pathophysiology details that you need to remember for this topic. And one simple English word that I can request you to remember right now, right here, that would help you understand. I mean, what's the problem in this patient is astrocytopathy. So this particular disorder would be causing damage to the astrocytes. Well, what is the damage present in this case? There's an antibody by the name of anti-aquaporin 4 antibody. What it does is it activates the complement system. It will cause a complement mediated damage. Due to the activation of the complement system, like we study about C5, the complement system, it gets broken down into C5A and C5B, which are called as anaphylatoxins. So the complement mediated damage will occur in this patient. And what is the site of damage? I did talk about it verbally. I'll just jot it down at the moment. The blood-brain barrier is getting involved in this case. So the technical answer would be foot processes of the astrocytes, where they meet with the endothelial cells. That's gonna be the site. I'll repeat that again. The foot processes of the astrocytes where they meet with the endothelial cells are the actual sites which would be affected, and this would be a complement mediated damage. Over and above this, in this condition, it has also been documented that the cerebrospinal fluid levels of interleukin 6 are elevated. Traditionally, we have read about interleukin 6 in COVID-19, where we used to read COVID-19 used to, and you would have seen also COVID-19 used to cause a development of cytokine storm. So today, the same cytokine interleukin 6 is also contributing to inflammation in the brain, damage to the blood-brain barrier. And the objective of studying all this is because we now have monoclonal antibodies that can decrease the attack rate of this condition by as much as 90%. Well, one monoclonal antibody that I'll be writing before you subsequently, but I'm saying verbally at the moment, is eculizumab. What it does is it binds to the complement system. Eculizumab has an alphabet C, so it binds to the complement system C5. It prevents the cleavage of C5 into C5a and C5b, and therefore if I say like this, that if I'm able to neutralize this complement system, then the damage to the foot process of the astrocytes and the endothelial cells can be prevented, or the attack rates can be reduced. Eculizumab would be decreasing the attack rate for this condition by as much as 90%. You see, multiple sclerosis obviously has a waxing and a waning course. We read about varieties like relapsing variety of multiple sclerosis, primary progressive, secondary progressive, that I've described in the previous video. As far as neuromyelitis optica is concerned, the disability caused by this disease in a single attack might be very, very severe, and I can say if it has multiple attacks, then the disability will increase much more significantly as well. Both are devastating diseases, but what I'm trying to say is that monoclonal antibodies are one of the main weapons that we have nowadays for both multiple sclerosis as well as neuromyelitis optica, with one of the important ones being discussed at the moment as eculizumab. Another monoclonal antibody is satralizumab. Now, how would satralizumab work? It will block interleukin 6 receptor. I said interleukin 6 values are elevated. If we neutralize the receptors for, or if we block the receptors for interleukin 6, even if it is elevated, it would not be able to cause this inflammatory damage to the foot processes of the astrocyte and the endothelial cells. So one of the main approaches that we have is either we gonna prevent interleukin 6 from acting, or we gonna prevent this complement system from fragmented into those C5a and C5b anaphylatoxins, and thereby the damage can be prevented. As far as the prognosis of this disease is concerned, guys, you could be having one involvement of cervical myelitis, and the problem with cervical myelitis is not only about quadriplegia. That is not only the sole concern. There can be even respiratory involvement in these patients because of the cervical myelitis component at C3, C4 and C5, and the worst case scenario in these patients can be development of blindness. In fact, the blindness can be seen developing in approximately 60% of all the cases, or 60% of the cases, by usually 8 years of diagnosis, and our objective is mainly to prevent this from happening. You see, acute attack can be easily managed with intravenous methylprednisolone plasma exchanges. It's wrong to say easily managed because the disability of the disease is very extensive, but I can say still we are in a position to go all the guns blazing and handle an acute attack. But the more important thing is to prevent those attacks, because the disability, once it occurs, if it's very severe and then there's an additional insult that is happening, the disability is going to worsen. So our main objective is to decrease the attack rate of these patients, and the survival rate of these patients is as much as 98%. That's not the issue. 2017 data says 98% of these patients would survive, but if they survive with blindness, that's gonna be like a curse, no? See, if somebody is blind since birth, that's a different issue. But if somebody gets blind in the most economically productive years of their life, that's a cause of concern, and that is what we are here for, that we would like to prevent. So once we understand the disability caused by the disease, let's now focus on the core clinical characteristics which are useful for diagnosis of this condition, and the mnemonic that we use for this is ABCDOM. Alphabet A would stand for area postrema syndrome. Well, area postrema, you are familiar as chemoreceptor trigger zone, so the manifestations would be simple to comprehend. That would be nausea, vomiting, and development of hiccups. Alphabet B would stand for brainstem syndrome. Well, brainstem syndrome will cause neurological manifestations that would be like stroke-like features with ipsilateral cranial palsy and a contralateral hemiplegia, which has been described even in stroke. The anatomy part is what I have covered with respect to, why do you get contralateral manifestations in brainstem stroke? Alphabet C would be the most peculiar part of this discussion because I'm talking about cerebral syndrome. This cerebral syndrome can be contributing to development of seizures, it can be contributing to encephalopathy, and traditionally we read about spinal cord involvement, and then we're reading about cervical myelitis, we are talking about optic neuritis, and suddenly seizures start coming in, encephalopathy start coming in. That's definitely, I would say, not in sync with the kind of topic that we are talking about. So we need to remember, why do we call it a spectrum disorder? Is because of one, that couple of other disorders that can mimic it, and at the same time this would be having a very varied clinical profile. So symptomatic cerebral syndrome can contribute to seizures and encephalopathy, but there is a rider here, there's a plus here, and with the plus he says that there might be a NMOST typical brain lesions. So what are those NMOST typical MRI brain lesions? Well, those typical MRI brain lesion would be described as cloud-like lesions. You see, just like in multiple sclerosis, I've described those perivenous demyelination contributing to Dawson fingers. I have spoken about shadow plaques, then astrocytic gliosis that occurs in multiple sclerosis. Here I'm focusing on cloud-like lesions that would be spread all over the brain parenchyma to the level that they can even act like a epileptogenic focus and can contribute to seizures in the patient as well. It's difficult to manage these patients because of extensive weight loss, though they are having adequate caloric intake, the nursing staff is taking good care of them, but we still have diencephalic syndrome. Diencephalic syndrome means that the hypothalamus gets involved in this patient, and hypothalamus is the head ganglion of the autonomic nervous system, thirst center, then satiety center, all of them are present in the hypothalamus, and the involvement of the hypothalamus then contributes to a significant weight loss in spite of adequate caloric intake. That's why the term diencephalic syndrome is to be remembered. You see, just like in cancer we read about cachexia, in the same spirit here I'm saying hypothalamic involvement, we're using the term diencephalic syndrome for significant weight loss in spite of adequate caloric intake. Then alphabet N would talk about increased daytime sleepiness. That's gonna be narcolepsy. Now we have to obviously differentiate narcolepsy from obstructive sleep apnea, so I've discussed that in the respiratory system where I talked about polysomnography, but this would be increased daytime sleepiness again because of the involvement of the reticular activating system that keeps us alert and awake. So let's do a recall of A, B, C, D, N before we move to O and M, which are relatively simpler. A would be area postrema, that causes nausea, vomiting, hiccups. Brainstem syndrome, that can cause a cranial palsy. Symptomatic cerebral syndrome, that can cause seizures and encephalopathy in the setting of those cloud-like typical MRI brain lesions. Then significant weight loss in spite of adequate caloric intake and excessive daytime sleepiness. Look at how huge and how broad the clinical profile of this disease can be. Over and above this, we can be having optic neuritis, which I've already explained. Most of the time he'll describe it to be bilateral, and then he'll also talk about LETM, that is longitudinally extensive transverse myelitis. So these are the core clinical criteria for diagnosis of neuromyelitis optica spectrum disease. Now obviously we need to do testing of the antibody, and there is a possibility that antibody might turn out to be negative. If the antibody turns out to be positive, then you need to remember that there must be at least one core clinical criteria to be present. I repeat that again. In NMOST, if anti-aquaporin 4 antibody is present based on an IgG cell-based assay, then we need one core clinical criteria with exclusion of alternative diagnosis if the test is positive. If the test turns out to be negative, then we need two core clinical criteria. I'll say that again. If the antibody test, anti-aquaporin 4 IgG class of antibody, IgG cell-based assay is positive, then we'll say we need one core clinical criteria with exclusion of alternative diagnosis. But if it is negative, it is two core clinical criteria plus additional MRI requirements. So I'll describe these additional MRI requirements on my subsequent slide. But this is an important part of this discussion in a sense that we always focus on this antibody being the main test for diagnosis of this condition. Yes, it is. It needs to be given the respect that it deserves. But what I'm trying to teach you is that even if the antibody test is negative, you still can be making a diagnosis on the basis of ruling out alternative diagnosis, and you need two core clinical criteria from the ABCDNOM that I explained to you, with additional MRI requirement that will be discussed on the subsequent slide. Now the additional MRI requirements can be total of 4 of them, so let's just compile them together. Point number 1 to be remembered is if we can demonstrate at least half of the length of the involvement of the optic nerve. This would be based on MRI, that half the length of the optic nerve can be demonstrated, or involvement of the optic chiasma. In multiple sclerosis, fundus would either be normal or we can be having papillitis. But when it comes to neuromyelitis optica spectrum disorder, in contrast to papillitis, the lesion is more posteriorly located. Either more than half the length of the optic nerve is demonstrated to be involved on MRI, or we are having involvement of the optic chiasma. The second one is much more classical, that is longitudinally extensive transverse myelitis. The definition of longitudinal extensive would be at least 3 or more than 3 contiguous segments of the spinal cord. And point number C and D that I'll say, SC stands for spinal cord, are again, I would say, would sound a little repetitive, but those technical terms are to be remembered. One is area postrema involvement, but instead of writing area postrema, he will say dorsal medulla involvement in this condition. What he means by the word dorsal medulla involvement, anatomically speaking, would be the involvement of area postrema, and that would explain the clinical profile of nausea, vomiting, and unexplained hiccups in these patients. In case part number D sounds repetitive, yes it is, but yep, we need to demonstrate brainstem lesions in these patients. The technical term that he'll be using in this case would be periependymal. You see, in multiple sclerosis, I was using the word perivenous demyelination. This time I'm using the word periependymal brainstem lesions. And well, how do these brainstem lesions look like? They are obviously hyper intense, but they are described as cloud-like lesions. So additional MRI requirements, I'll just state them once again, would be demonstrating half the length of the optic nerve or involvement of optic chiasma, LATM, which has been talked multiple times, then dorsal medullary involvement, that's area postrema, periependymal brainstem lesions, and these additional MRI requirements are only required if we are able to have negative test with 2 core clinical criteria. That would still seal the diagnosis of neuromyelitis optica spectrum disorder. In contrast, if it is positive test, then 1 core clinical criteria would be sufficient for diagnosis with exclusion of alternative diagnosis. Before we focus on the treatment part of this condition, I would also like to invest a bit of time on the clinical profile. NMOSD, the ethnicity of the patient would either be Asian or African. In contrast, the right hand side, multiple sclerosis will mainly be a white male or a female. Mostly will be a female because we're talking about autoimmune disorders at the moment. And the clinical features on the left hand side will talk about bilateral optic neuritis, longitudinal extensive transverse myelitis, and those core clinical criteria that I have mentioned by the ABCDNOM mnemonic before you. On the right hand side, he's gonna mainly talk about unilateral, and he's not gonna straight away talk about blindness part. He'll say that the person had to go multiple times to her optometrist because her vision has decreased and she thinks that she needs a new pair of glasses, and the optometrist was not able to help the patient. Or current visit, she's saying that I've got my glasses checked multiple times, and today when I've come to you, doctor, like she's wearing a colorful dress and she says that I'm not even able to see the colors in my dress. I mean, that's the amount of disability, the decrease in color vision of this patient would be happening. So, but however, the longitudinal extensive transverse myelitis part, the core clinical criteria would not be described for multiple sclerosis. For MRI brain, the keywords would be a cloud-like lesions, that is the hyperintense lesions that I'm talking about. And as far as multiple sclerosis is concerned, he'll talk about Dawson fingers or the perivenous demyelination. Do we have a spine involvement? Yes, we have a spine involvement spanning at least 3 or more contiguous spinal cord segments. For the spine involvement in multiple sclerosis may or may not occur. If the lesions occur, and if suppose they could be causing a detrusor dyssynergy, a patient might be having difficulty in initiating the active urination. So per se, I can say bladder and bowel involvement can be present in both of these disorders, but then the disease would be much more extensive, contributing to focal spinal cord atrophy, I mean, that's an additional term that I'm using, focal spinal cord atrophy, that could be seen with NMOSD but unlikely to be present or less likely to be present with multiple sclerosis. Then association with autoimmune disorders will really not help, but just for the sake of completion, as far as the left hand side is concerned, NMOSD association can be with SLE, or it can be with Hashimoto's thyroiditis, or it could be with P-ANCA associated vasculitis. Multiple sclerosis again is associated with autoimmune disorder, that would be hypothyroidism. So this slide will not help in diagnosis. The main diagnosis would be based on the aspects which I mentioned on this particular slide. And then more importantly, the MRI would also help. And for the right hand side, we need to use the revised McDonald's criteria for diagnosis. We need to prove dissemination over time or dissemination over space, which I've described in the video of multiple sclerosis. As far as CSF findings are concerned, the CSF of neuromyelitis optica spectrum disorder might talk about increase in neutrophils, increase in eosinophils, and even the description of oligoclonal bands may be given, but in less than 20%. You see, on the right hand side, for multiple sclerosis, oligoclonal bands are usually demonstrated on CSF electrophoresis. The meaning of the word oligoclonal bands, or why they are important, is that they signify intrathecal spinal cord based or intrathecal synthesis of the antibodies. You see, the antibodies in multiple sclerosis, obviously T cells play a role, the autoreactive T cells, but then antibodies are synthesized in multiple sclerosis inside in the brain as well, in the spinal cord as well. Whereas when it comes to the left hand side, it would may or may not be present, in a sense that I said the percentage of oligoclonal bands would be less than 20%. Do listen to the diagnostics of multiple sclerosis. If you come to this video directly, I would also suggest you to one, compare the pathophysiology of multiple sclerosis versus pathophysiology of neuromyelitis optica, gross differences between the two. Like, I'll say the term again, perivenous demyelination, then astrocytic gliosis. Those are the kind of terms that would be described for MS, whereas for this, it would mainly be astrocytopathy. And then I also described the local development inside the brain itself. There's this development of antibodies which are contributing to demyelination, though even axons can be involved in multiple sclerosis, but the pathological hallmark of the disease would be presentation of demyelination. Now let's look at what do we do for management of our patients. So if it's an acute attack of neuromyelitis optica spectrum disorder, we'll be using intravenous methylprednisolone. Along with this, we'll also be going ahead with plasma exchanges. So the main treatment, 5 to 7 plasma exchanges, would be methylprednisolone and plasma exchange. Methylprednisolone also plays a role in prevention as well, but we have a couple of more effective drugs available. So let's look at what we can be using for prevention of attacks of neuromyelitis optica. We can be using mycophenolate. At this point, I would like to say beta interferon, glatiramer are the traditional drugs that we read in multiple sclerosis are ineffective in this case. Beta interferon, glatiramer are ineffective for management of this patient. So it's going to be mycophenolate, then methylprednisolone, I mentioned rituximab, and then we also have monoclonal antibodies. One of the most important monoclonal antibodies from the exam perspective that you should be remembering from this topic is right on the slide before you, that is eculizumab. Well, the mechanism of action of this molecule will be, it will bind to C5, which is one of the part of the complement system, and it will inhibit then the cleavage of C5 into C5A and C5B. These C5A and C5B are ones that are called as anaphylatoxins, and once you inhibit the cleavage into these components, the anaphylatoxins component, then that complement mediated damage can be prevented. As far as inebilizumab is concerned, what it will do is it will bind to the B cells, it will bind to CD19, and it will cause a B cell depletion. So what we are trying to do with help of monoclonal antibodies is cause a immunological modulation of the disease process per se. And then I also said in the starting of this video that in NMO, we have increased CSF interleukin 6. So what this molecule will do is that this molecule will bind to interleukin 6 receptor, and as a result of it, the attack rate in the patient would come down. Out of all the antibodies that I mentioned here, there is a comparison As far as eculizumab is concerned, the attack rate can be reduced by as much as 90%. As I said, our main objective is to prevent the cervical myelitis component and also reduce the chances of development of blindness in these patients, which could be developing by about 6 to 8 years of the diagnosis per se. So these are the details that I would like you to remember for this topic. I know that some additional details like the core clinical criteria and then the details that I made you remember, even if the anti-aquaporin 4 antibody might sound a little overbearing for you, but I assure you that this is worth the effort. In fact, kudos to you. Most guys give up when they start reading multiple sclerosis, and most guys give up when they start reading 1.5 syndrome and 8.5 syndrome. But you did multiple sclerosis, came to this particular video of NMOSD, so kudos to you. And I think you are doing the right thing by focusing on this data. When I talk to people, a lot of people say, sir, you are focusing on only clearing an exam. Well, what I'm trying to focus upon is not clearing an exam. My focus is hardcore theory. If your theory is good, man, any exam, whether it be a short case, long case in a ward, or it's gonna be, I would say, a competitive exam, you would be able to ace all of them. So it doesn't matter. I can say if theory of somebody is strong, then he is good with everything else. It is not that if you stand in the ward for a few hours, you will imbibe some information. You have to learn theory first. Then you go in the ward and then you try to apply. You will be able to see much more things beyond than what your eye tends to show you at this particular point of time. So build up your theory. Keep the pressure on, keep hammering, keep on learning new things every single day. And I'm very sure that you're gonna do, or I would say break on to the other side, or you're gonna do great in your careers. Thank you so much.